All right, so I'll be presenting the first case today, and I have Dr. Justin Bullock as my clinical discussant. So, Justin, I will hand it over to you.
Thank you very much. You get to the next slide. This is a case of a woman who presented with neck pain and hypertension to the ED. She's 38. She recently immigrated from Ethiopia. Um, she was basically riding in the car with her friend and noticed kind of acute neck pain and tightness, which basically has persisted for a few hours. She had no fevers or chills, shortness of breath or chest pain, no nausea, vomiting, or diarrhea. She had recently presented to an outside ED a few days prior. She had had lower extremity swelling, which went up to her thighs for the last 6 weeks, as well as eye pain. When she went to the outside ED, she was told that she had very high blood pressure. She was unsure how high it was given losartan, was told she had normal kidney function at that time. So now this is a few days later. She presents in the ED at Harborview with blood pressure of 183 over 103. Had basic labs which showed normal kidney function, a UA which had 3 plus protein, which was 11, almost 12 grams on UPCR, almost 9 grams of albumin. And the UA had 3 plus RBCs, both in the dip and then, yeah, in the high power field. So she was referred to primary care, who then referred her to nephrology. When I saw her in kidney clinic, she had both lower and upper extremity edema to her thighs and mid-arm, respectively. She's still having headaches, which she says improves with ibuprofen and Tylenol. She says she takes ibuprofen occasionally, but not very frequently. She was on losartan, also had intermittent nausea, bloating, and hematuria. Otherwise, her review of systems was largely negative. No chest pain, dyspnea, orthopnea, no dysuria, hematuria. Oh, sorry, she had hematuria. No weight loss, recurrent UTIs, etc. And as far as medication, she was taking the losartan, vitamin D, fish oil, and a curry pill, but unsure what that was. No other vitamins or supplements. I guess can we go back one slide? I'll pause and ask if people have any other history questions they want to know at this point.
You may have mentioned it, but no other past medical history or diagnosis in this lady.
Correct. She was otherwise, yeah, no past medical history. Okay, maybe go to the next slide. Thanks. So these are her labs in clinic. Sodium 138, K 4.2, creatinine 0.71, which is similar to the two prior lab values that she had. Had an albumin of 2.9, a CBC, which was normal, Hep B, C, HIV negative. We sent workup for proteinuria. And sorry, I didn't say well, I guess PLA2R is negative, ANA, ANCA is negative, C3, C4 was normal. Her urine sediment had multiple RBCs. Some of them were dysmorphic. Had one questionable, something that looked somewhat like an RBC cast. Um, as you can see, she has hyperlipidemia. And then an SPEP had been sent by the primary team. I actually would not have sent it given her age of being 38, but she basically had an IgM kappa. Um, uh, and I believe the um, on electrophoresis, I believe the spike was zero point 0.3, but I'm forgetting right now. Any other lab information people would want? So at this point, when I saw her in clinic, um, because the magnitude of the spike was relatively small, um, I didn't really know quite what to make of this SPEP. She had a lot of features that are consistent with nephrotic syndrome, edema, hypoalbuminemia, the proteinuria, hyperlipidemia. I didn't see any um, oval fat bodies on her urine sediment, but also the question mark RBC Cas also made me wonder whether she had a GN. Okay, next slide. Anand, I think it's you. Yep, thanks.
All right, so I'm going to start with asking you all. Oh, let me set up my anonymous annotations if I can remember how to do that. There we go. Okay, so you should all be free to anonymously annotate now. So if you want to mark what diagnoses you might suspect in this case, and in the meantime, if anyone has other questions for Justin, you're also welcome to ask away. Oh, the annotations show up on my other screen there. So I see a few scatterings kind of across the board. So broad differential for this case, which I agree with. We have, yeah, so there's a lot of votes for FSGS, but really any of these causes of nephrotic syndrome or glomerulonephritis, all possibilities in my mind going into the biopsy. Great, thank you all. So, okay. So let's go ahead and look at the biopsy. So here I have a low power view of the biopsy core. Justin sent us a nice sample, one big piece of cortex and another piece that's kind of at the corticomedullary junction here. Um, and um, and so at low power, really helpful to get an overall sense of the chronic injury. And we're seeing tubules that are fairly back to back and nice and pink as we'd expect to see from proximal tubules in the renal cortex. Oh, uh, does someone mind helping clear the annotations, please?
Sorry, it looked like for whatever reason it didn't assign me as the host. Alyssa, are you able to swap host to me? I can clear the annotations on my end, unless you're able to do it.
I don't see a place to do it.
All right, got it.
Great, thank you.
Mhm.
Okay, so so yeah, I saw a few votes for mild. Thank you. So this is the tubular atrophy and interstitial fibrosis is quite mild in this case. There's a few areas where there's maybe a slight bit of atrophy in these tubules where you see a darker outline around the basement membranes, but for the most part, the cortex is well preserved, which we'd expect given her stable serum creatinine. And then I have the glomerular counts for you, a really good number of glomeruli and only up to one per level that's globally sclerosed. Okay, so we'll start looking closer at the glomeruli, and hopefully you can see that these glomeruli look abnormal. I'm showing you a selection of 6 out of those 30 to 40 something glomeruli, and this was a diffuse finding. Really, all of the glomeruli looked more or less the same. Um, and here's a slightly larger view of one of these representative glomeruli. And so what really stands out is that we're seeing a lot of this pink or eosinophilic material throughout the glomeruli. And then the mesangial regions don't quite catch our eye as much, but these are also expanded mesangial regions. And we're seeing both increased matrix and cells in these mesangial regions. Um, Okay, so I have this question here about what we think the eosinophilic material is. Often when I have, especially when I have early residents with me, one of the challenging things to learn is distinguishing between different types of material we can find deposited in glomeruli, which will all have a similar eosinophilic appearance. Um, and um, and it's not always straightforward to distinguish between them. So in this case, just based on this Jones stain, I can't really tell with certainty what this material is composed of. I will note that it's not collagen because on a Jones stain, the extracellular matrix proteins like collagen will appear black, but all of these other types of material can appear eosinophilic or pink on a Jones stain. And fibrin tends to be a little bit brighter pink. So looking at this, I did not think this was all fibrin, but hyaline immunoglobulins or complement and amyloid can all look pretty similar. So I'm going to go slightly out of order from our usual and show you the immunofluorescence first, and then we'll go back to the other stains. Okay, so here's the immunofluorescence, and we see strong staining for IgM. We see strong staining for kappa, and kind of modest, maybe non-specific staining for lambda. Um, and so this helps us because sometimes eosinophilic material can be just hyaline or fibrin, and so we're seeing that it's in fact made of immunoglobulins, not some of those other types of material. So when I see monotypic IgM deposits, I'm most concerned about two main disease processes or patterns of deposition, which are amyloid and cryoglobulin. So I'm going to go back to the Jones and the other special stains and see how we can distinguish between these different patterns of IgM deposition. So here's the Jones stain again. On the Jones, both of these could appear eosinophilic. The amyloid tends to be maybe a little lighter or weakly eosinophilic, but not very reliably. This material stains strongly positive on the PAS stain. It's this bright pink or fuchsinophilic appearance on the Meson trichrome stain, and then importantly, the Congo red stain is negative. So all of these stains are pointing us towards um, deposits like cryoglobulin rather than amyloid. Um, some of the other types of immune deposits besides cryoglobulin can have a similar staining pattern, but we're at least excluding amyloidosis based on the Congo red and these other stains. And we're thinking more of an immune complex process and high suspicion for cryoglobulin given the composition of IgM. Okay, so in cryoglobulin, so actually first let me just give you a closer look at a glomerulus again, and I'll point out more specifically where we're seeing these deposits of eosinophilic material. So there are some areas like here and here where we can see the eosinophilic material is in between the lumen and the basement membrane. So these are subendothelial deposits. And in occasional segments, we can see duplication of the basement membrane. So there's one contour and a second contour of basement membrane wrapping around this capillary wall. And that's a common reaction to the presence of deposits that can be in the capillary wall. Um, and for a diagnosis of cryoglobulin, we're in particular looking for what we call cryoplugs. And this is where you see the eosinophilic deposits within the lumen of the capillary. And the extra tip-off is seeing this rim of white empty space around the periphery of the deposit, because often the subendothelial deposits will just protrude into the lumen, but seeing this rim going around gives us a high suspicion that what we're seeing are cryoplugs. And then lastly, I'll point out that there's a little bit of increased cellularity within these capillary loops, but it's really not as prominent as we often see in cryoglobulin or other membranoproliferative glomerulonephritis. Okay, so I'm going to go briefly through the electron microscopy. Here's a low magnification image of one of the glomeruli by EM. And what we're seeing is just a whole bunch of these electron-dense deposits in the glomerular capillaries. And there are some areas like here where they're somewhat clearly in the subendothelial space of the capillary wall. So here's the lumen. There's a little bit of basement membrane out here, and we're seeing deposits in the subendothelial space. And then there are many more places where we really can't make out the capillary architecture much at all. These deposits are just really filling in a lot of the luminal spaces. Okay, so a major feature that we often see in cryoglobulin cases is substructure. So if you look closer at the deposits, they'll have a fibrillar or a tubular or a fingerprint kind of pattern to them. And I didn't find any definitive substructure, but there are a few images here where you can maybe get a hint of some texture to these deposits, and it's not just like solid gray. Um, yeah, so not definitive, but a suggestion of some substructure to these deposits. So at this point, what I told Justin is that there's an immune complex glomerulonephritis. It's composed of IgM kappa, and I phrased it as being suspicious for cryoglobulinic glomerulonephritis. I was maybe being a little bit cautious here because the features really fit quite well with cryoglobulin. We have these PAS positive deposits that are composed of IgM kappa. Um, and the what was kind of interesting, and I'll point out a little bit in a few minutes in more detail, is that the we generally associate cryo with a membranoproliferative pattern of injury, and really the both the basement membrane changes and the proliferative change was not that pronounced in this case compared to how really prominent and widespread the deposits are. Okay, so I'm going to make a few brief learning points about cryoglobulin. First, I want to briefly review the types of cryoglobulins that I always have to review. So type 1 is composed only of monoclonal immunoglobulins, most commonly IgM kappa. And these cases of type 1 are almost always associated with an underlying lymphoproliferative disorder. Whereas type 2 and 3 are mixed cryoglobulins, where in type 2, there's a monoclonal component and a polyclonal component. And in type 3, there's polyclonal, both IgM and IgG. Um, and in this case, I didn't fully commit to what type of cryoglobulin we were seeing. And the reason for that was that the deposits looked, so there was only IgM. I did not see any IgG or IgA, but I saw a striking bias, but not an absolute bias in the light chains. So I saw mostly kappa, but a little hint of lambda. So it kind of looked most like a monoclonal process, but because there was that hint of lambda, I wondered whether there might be some polyclonal IgG in the background that was just below the limit of what we could detect. So in this case, because I couldn't tell confidently, I basically recommend looking for any underlying condition, whether it was a B-cell lymphoproliferative disorder or hepatitis or other chronic infections. Although I'll note that the infectious workup at the was negative already. Okay, so I'm going to just finally briefly review some of the typical features we see in cryoglobulin cases. These images are now not from this case, but from the Atlas of Renal Pathology. So the characteristic staining pattern is to have these strongly PAS positive deposits. The classic is the cryo plug, which we have a nice example of here, where where it's sitting inside the lumen with a rim of white space going around it. And we mainly look for these within glomerular capillaries, but they can also be present in extraglomerular vessels. And the classic pattern of injury is membranoproliferative, meaning that there is increased cellularity within the capillary loops and basement membrane duplication. I'll note that the basement membrane duplication is kind of a response to the chronic injury. So depending on the timeline, you might not get a lot of basement membrane duplication if we get an early biopsy. But most of the time we see advanced endocapillary hypercellularity. And that's seen in this case here where we see some loops that are full of cells in addition to the deposits. In this case, there was not a lot of endocapillary hypercellularity. Some of it might have been obscured by the deposits, but overall, it was interesting to me that there was not that much reaction to the deposits. Less commonly, there are cases that are just mesangial proliferative, and in those cases, there's usually not as widespread of deposits as we saw here. Okay, and then immunofluorescence, again, we'll expect to find immunoglobulins, most commonly IgM, more commonly kappa than lambda. And most cases also have C3, which I did not see in this case. And then as I mentioned before, cryoglobulin cases often have substructure, and so here are a few examples of what substructure can look like in more clear-cut cases. All right, so I will stop there with the pathology. Unless anyone has questions, I'll hand it over to Justin for follow-up, and I'll check the chat for any questions. Yeah, and Dr. Smith makes a good point that the rheumatoid factor can mask detection of IgG, so it's difficult to exclude a type 2.
Thanks, Anand. After Anand sent the biopsy results back, We sent a rheumatoid factor and cryoglobulins. I think the UPEP had been sent before, basically kind of with this equivocal sort of comment, some protein band in Europe, but unlikely to be monoclonal. The rheumatoid factor was elevated at 214, and the cryos at day 10 were 1.3. Um, so at this point, given the concern for cryoglobulin GN, we referred to hematology oncology, who she actually saw yesterday, and they said that they thought that this procedure was consistent with cryos, that she didn't have any other evidence of hematologic malignancy, no hypercalcemia, no renal abnormalities. She did have anemia, but that was basically only following the biopsy. She was not anemic before the biopsy, and we had not done any workup for bone-related things. Um, they thought that this was most likely consistent with the type 2. I think given the rheumatoid factor, the IgM spike, and other clinical presentation, but no clear cause for why she would have a type 2 cryoglobulinemia. And they recommended rituximab as the initial treatment, which they are planning to start sort of imminently. And that is pretty much the update.
All right, thank you, Justin.
Justin, I have a question. Was Plex ever considered?
They said that I think they had considered it. They at least wrote in their note that they had considered it, but I'm not sure why they chose rituximab alone as opposed to Plex and rituximab.
And how is her kidney function?
It's still
Interesting.
normal. 0.6, 0.7 is her creatinine.
Justin, it seems a little surprising to me that they didn't decide to do a bone marrow biopsy up front.
I
Did
agree.
they discuss their thought process on that?
No, they didn't actually even comment on it in their note. Um, because the referral was specifically for a question of whether or not bone marrow biopsy would be helpful. I think because yeah, my assumption was them saying because she didn't have any other systemic sort of symptoms that they thought that it was relatively low probability, or that I'm not, I guess maybe that the bone marrow biopsy wouldn't sort of wouldn't change their, um, I'm not sure, basically. I'm just looking at the net one second, see if they say anything. Yeah, they don't comment further.
All right, thank you all. I'll stop sharing and hand it over to Bazat for the second case.
Okay. Good morning, everyone. So I just sent a request. Okay, now I can share my screen. Ready? Let's go to.
And just to give a shout out, I texted Bang at 11 p.m. last night as I was prepping the cases, and I realized this case was actually his case and not my case. So thank you, Bang, for being willing to jump in with 8 hours notice.
All good.
Yeah, thank you. It's the first case also was very, very interesting. Thanks, Anand. It was a very nice case of cryo. So let me see. I have to, I think, swap the presentation. Okay. Now, can you guys see my screen? Well,
Yep, it looks great.
okay, fantastic. All right. So Dr. Bollick is going to discuss the clinical part of case number 2.
All right, so I'm actually going to be talking about this patient. But this was back in 2022, a 63-year-old gentleman with worsening proteinuria, worsening creatinine, and hypertension who was referred to the renal clinic. Prior to this, he had gone to the ED. They found him to be hypertensive. He got sent to the cardiology clinic, who noted his creatinine was worsening and was eventually referred to us. And then a UPCR then showed 11.7 grams per gram of proteinuria and albumin creatinine ratio of over 7,000. His serologic workup was, negative for infectious workup, autoimmune workup, C3, C4. But subsequently, a ASPEP then showed a small IgG lambda MGUS, and then also his kappa and lambda free light chains are pretty normal actually. But because of all of this, he underwent a kidney biopsy.
Okay, thank you. So please mark your top differential diagnosis based on this clinical history. And could you remind me? Let me see how I can make the annotations anonymous. Are they anonymous now?
Yeah, anonymous.
Can you do that, Daniel, on your end, or is something that I should do?
I'm not seeing notification of who's doing them. Are others seeing that? They look anonymous to me.
Okay, all right. So we're good.
Oh, no, maybe not.
Okay, I mean, I'm not sure if everyone is okay with that. If they are, we can just continue.
Yeah, for me, the option was, I don't remember what the menu exactly said, but in the top right, I clicked a drop down and it said hide annotation names or something like that. But depending on how your Zoom is loaded, I think it can look different.
Yeah, I don't see do that. That's the mice. Yeah, no, I can't find it. But if anyone knows how to do it, let me know, and I will do that. So let's. I would say let's continue. Um, okay, are you seeing my screen? No.
Yep.
Yeah. Why? Okay. Now.
I see the pathology slides at
All right.
2022.
This is the biopsy, the first biopsy, the kidney biopsy that was done for this patient. And as you can see, there are two biopsy cores. In terms of chronic injury, I would say at least moderate it looks like, but also there is a lot of fluid stuff, so there is inflammation, so that may be an overestimate at the same time. There were 13 to 14 glomeruli in the biopsy core. Up to 14% of them per level section were globally sclerosed. And this is how the glomeruli look like. Pretty much all of them look like this. And what do you think about this? Which ones are present in this glomerulus? You can check mark more than one, definitely. Nodular glomerulosclerosis, MPGN, mesangial mesangial hypercellularity, and endocapsular hypercellularity. Okay, mesangial, yes, I can see that in areas that, we have dilatation of the loop, we have fraying of the mesangial region, which should be black like this, but it's not. Okay, nodular glomerulosclerosis. Yes, there is definitely nodular glomerulosclerosis, as you can see. That is correct. And endocapsular hypercellularity, I would say that that is correct as well. When you look at the capillaries that are on the periphery, many of them are filled maybe by swollen endothelial cells or infiltration of the leukocytes or macrophages. So there is endocapsular hypercellularity. So no one checked the mesangial hypercellularity. I think that there is some mesangial hypercellularity present as well. I mean, in the mesangial regions, we have 4 or more nuclei seen. We have mesangial hypercellularity, so there is some of those available as well here. What about the MPGN or membranoproliferative glomerulonephritis? So that would be when the lobular pattern of the glomerulus is accentuated, similar to this. We see segmental duplication of glomerular basement membrane, and typically we may see influx of leukocytes or hypercellularity as well. So I would say that, one can find any of those in here in this glomerulus. Okay, so let's look. This is a closer look of another glomerulus. As you can see, nodular glomerulosclerosis. I mean, all of those things that you mentioned, and they were all correct. And interestingly, another finding was that we also had these kind of like eosinophilic deposits mainly in the peripheral capillary walls, but also, I mean, aside from this, which is a podocyte on the outside and shows some cytoplasmic granules that are eosinophilic. We can see them in conditions that we have podocyte injury, but also we could see in some of the, looks like capillary groups, we had similar kind of material, which looked like it's intracellular. So we were curious what those things are, and we did some studies that I will show you. Okay. So as I said, there was some chronic injury. As you can see, tubules are not back-to-back, and there is a black material, which means there is interstitial fibrosis. We have tubular atrophy, and also these are all mixed with the inflammation. And that was at least moderate, so it looked kind of like significant. The majority of the cells in the interstitial fibrosis part, there were lymphocytes and plasma cells, as you can see, but also there were some eosinophils, as you can see, but predominantly was a lymphoplasmacytic infiltrate. These are atrophic tubules, as you can see, with thickened basal membranes and duplication of the basal membranes. Okay, so far, which ones do you favor? Based on just what we have. So nodular glomerulosclerosis, mesangiolitis. Also, there were some other features, mesangial hypercellularity, endocapillary hypercellularity. So which one of these? Diabetic nephropathy can cause nodular glomerulosclerosis. Light chain deposition disease can cause nodular glomerulosclerosis. Glomerulonephritis. Did it look like what Anand showed? Although I have to say that what Anand showed was also, well, it was kind of, not the most typical, because as he mentioned, there weren't a lot of like influx of leukocytes. PGN-MID can look like that. IgA, idiopathic nodular glomerulosclerosis. Okay, so we have two things: light chain deposition disease, PGN-MID. Well, we have to go and look at the immunofluorescence study. All right, so this is the regular immunofluorescence microscopy. I'm just showing IgG cap and lambda in here, but pretty much all of the immunofluorescent stainings were negative. Was that to our disappointment? So which ones do you favor now? Did you change your mind? So immunofluorescent is negative, but we had nodular glomerulosclerosis, we had mesangiolitis, we had hypercellularity, idiopathic nodular glomerulosclerosis, diabetic nephropathy. In the history, the patient didn't have diabetes, though. So, okay. So, all right. So let's see if we can find those changes that we expect by electron microscopy. And this is how electron microscopy looked like on low magnification. So as you can see, there is kind of like nodular glomerulosclerosis here. This is the mesangial region, a lot of mesangial matrix. And at this low magnification, I don't see obvious, I see some. Let's focus. But in this area, in the central area with nodular glomerulosclerosis, I'm not seeing obvious deposits in here. And this is a closer look to that region, and you see a lot of, so kind of, I would say, I mean, when I look at this image, the first thing that comes to my mind would be diabetic nephropathy, except for that glomerular basement membrane were not looking that remarkable, and the patient did not have diabetes. And here I'm saying that mark the immune type deposits. So if you believe me, you would think that there are some immune type deposits in here. If there are, you think, could you mark them? Very good, fantastic. So as you can see, although in the middle part, we didn't have obvious deposits, in the periphery, kind of still you could say that in the mesangial region, there were some areas it was difficult to say. And so, for example, this might be a GBM duplication, but also it looks like that these are now we have interposition of the mesangial cells. So kind of these regions are mesangial or have become mesangial regions. And exactly, we see immune type deposits in these areas. Also, corresponding to those cells that I showed to you with those granules, we were seeing these cells that probably they were macrophages. And they look like they're lodged in the capillary lumina, or maybe some of them in the mesangial regions. But you see that there are areas of the glomerulus with not much deposits despite these. So wondering, okay, what these cells are, staying for CD68, and there are CD68 positive. Okay, so we have macrophages infiltrating into the glomeruli, maybe for those deposits. Okay, so immunofluorescence was negative, but electron microscopy showed deposits. What would you do next? What would be your next step? Pronase digestion immunofluorescence. Wonderful. Yes. So in conditions where we have abnormal immunoglobulins, misfolding, and we need to do basically expose the epitopes that can be recognizable by our antibodies, we use pronase digestion immunofluorescence. We can also do mass spectrometry if for these conditions. So those options are available. We also Congo red. We didn't see fibrillary by electron microscopy. Well, we would do Congo red in this case anyway, because I would say that we had the patient had a history, and also if we suspect amyloid, but by electron microscopy, I didn't suspect amyloid really, because we didn't see fibrillary deposits, right? We saw kind of like immune type deposits. Okay, so pronase digestion immunofluorescence, and we did that, and it turned out beautifully fruitful. So IgG, kappa, and lambda. As you remember, in the first stain, regular immunofluorescence, they were all negative, and now we were seeing bright staining, kind of following the same pattern that we were seeing by electron microscopy, more in the periphery, and also some in the mesangial regions. For IgG, nothing for kappa, but also for lambda. So now, what is the diagnosis? Now, you have enough information to establish a diagnosis. And what would that be at this point? Diabetic nephropathy, light chain deposition disease, cryoglomerular glomerulonephritis, PGNMID, IgA nephropathy, idiopathic nodular glomerulosclerosis, or fibrillary glomerulonephritis. Light chain deposition. So in the light chain deposition disease, what you expect is that by immunofluorescence, you have all those linear stainings of the tubular basement membranes, of the glomerular basement membranes. You need to see powdery deposits by electron microscopy. Fantastic. PGNMID. Okay, and I agree with you. IgG, lambda, PGNMID, proliferative glomerulonephritis with monoclonal immune globulin deposition disease. But I said with monoclonal, so let's put that aside for now. At the end, we will talk a little bit about that. So for the follow-up, now let's listen to the follow-up.
So after the initial biopsy, there was concern for MGRS and PGNMID, and he was referred to hematology. He did undergo a bone marrow biopsy then. The results itself weren't super crazy, but on cytology, flow cytometry, it showed concern for a small plasma cell group, and then he was started on Cybor-D. He completed 6 total cycles, really minimal improvement in his proteinuria. His UPCR had dropped from 11.7 initially to maybe now the somewhere between a 2 to 5 range. So improvement, but still did not get rid of it. The IgG lambda stayed stable despite treatment, and his free light chain ratio had been normal throughout his entire course. So because of this, for the next year or two, because of the stability and his continued proteinuria, we reached out to onconephrology at UW at that time, and it was recommended we get a repeat biopsy.
And a repeat biopsy was done. This second biopsy, Dr. Smith looked at this, and basically, the light microscopy findings were kind of similar to what we saw in the beginning. Well, in retrospect, when I'm looking at this, maybe a little bit less inflammation, but still we have quite prominent nodular glomerulosclerosis, as you can see, and as you said about the first biopsy, we see the same thing in here. And we have some of these eosinophilic material, as you can see, is still in these regions, although I have to say that by light microscopy, it's very difficult to say whether these are immune type deposits or these are hyaline. And that's why we do immunofluorescence and other type of studies typically, right? Okay, so this is how the second biopsy looked like. Most of the glomeruli, very similar to these. But it was interesting. The chronic injury may be a little bit less compared to the first biopsy. That was at least moderate, and this one was like kind of more on the mild side, mild and patchy side. Maybe because of the variability in sampling, or maybe because there is less inflammation following the treatment, or maybe there is some remodeling in the tubular interstitium. Anyway, let's look at the immunofluorescent microscopy. So the immunofluorescent microscopy, they showed some highlighting the accentuated background of IgG and lambda, but really, and this is regular immunofluorescent microscopy. Remember, this is the protein digestion, but did not show like bright brisk type of staining, more similar to this C3, which was like 1 to 2 plus. And we can see that in cases with segmental sclerosis and when there is injury. So it's difficult, I would say, that with this pattern quite be certain that, okay, I mean, this is really C3 deposition or not. We have to often correlate that with electron microscopy and other things. Anyway, and fibrinogen showed a little bit of highlighting here that was interpreted as probably mesangiolisis. So that's how the regular immunofluorescence looked like. But in contrast to the first time, it looked like protease digestion immunofluorescence was negative. Okay, how about the electron microscopy? Are we seeing similar findings to the first biopsy by immunofluorescence? So this is a low magnification. So for your reference, on the right side, you have the Bowman's capsule. And then here is the tuft. And I've marked some of the regions, like the mesangial, red blood cells, so you can identify that these are the capillary lumina or the podocytes that are sticking on the outside. So let's go on a higher magnification. And by higher magnification, again, I'm writing here marked deposits. So we've got to have some deposits here. Could you mark them? Yes. Wonderful. Yeah. So segmentally, there were still deposits. There were deposits kind of similar to the first biopsy. We see that podocytes show quite significant food process effacement, so there's podocyte injury as well. But we have mesangial, we have subendothelial, immune type deposits, and no substructure, by the way. I mean, I didn't talk about substructures in the first biopsy. And we had also, you remember those cells that I told you about the macrophages? I want to say that it looked like in the second biopsy, they were kind of even more prominent, as you can see them. And also, they contain these probably lysosomes filled with very dark material, and some of them maybe a little bit crystalline material. I mean, even if I see crystals like this, is this a granulocyte that we're looking at? Or is this really a macrophage containing these abnormal proteins? But there were quite a few of these. scattered throughout the capillary tuft. And again, we have the deposits distributed along the capillary walls as well as in the mesangium. Again, more in the peripheral side. And here I'm marking those deposits as well as I'm marking those cells that are likely the same macrophages that we saw the first time. Some of the capillary loops contained something that looked like chunky deposits mixed with red blood cells and also the mesangium, that maybe there is an element of mesangial even in that, because everything is mixed and hard to tell where we are. Again, we have this electron-dense material, most consistent with the deposit, but in some areas, also some capillary loops showed very significant remodeling, as you can see, like this kind of is reminding us like what we see in the microaneurysm in diabetic nephropathy. And you don't see any endothelial lining in here, so kind of there is mesangial as well. And you see those macrophages containing those dark and maybe some of those crystalline material too in this glomerulus. Again, other capillaries and the same macrophages, but interestingly, as you can see, if you follow the borders of these cells, you see that these deposits, some of them they look like, at least that they have been being engulfed and gobbled up by these macrophages. In some capillary loops, you don't see obvious deposits, but there is some like GBM duplication. There is expansion of lamina or interna, indicative of endothelial depth. So here the stars are showing the deposits. Also, we had areas of mesangial where the mesangium is not compact anymore, such as in here. It's pretty loose. It's edematous. The cells are sending these projections here and there. And in those areas, not necessarily we had deposits such as here. I don't see obvious deposits, but we have mesangial Podocytes, again, show very significant food process effacement. Okay, all right. So there were some differences, excuse me, in the second biopsy compared to the first one. As you saw by Perner's digestion immunofluorescence microscopy, there was no staining. So because of that, it was called persistent glomerulopathy with diffuse and nodular mesangial sclerosis, basically a descriptive description of the appearance of the glomeruli, because the immunofluorescence component for calling it PGNMID this time was missing. And because of those areas that I showed, we had mesangial we had some GBM duplication, expansion of lamina or interna in areas that obviously there were not deposits. The concern was raised that maybe there is an element of thrombotic microangiopathy as well. Now, and also as you can see, thrombotic microangiopathy is in this comment. And as you know, it can occur in the context of monoclonal gammopathies as well. And in fact, there are case reports of concomitant PGNMID with thrombotic microangiopathy. Okay, so this was biopsy number 2, but the story continues.
So after the second biopsy, he still had pretty high proteinuria, and we try to maximize antiproteinurics. And despite that, you could see in the graph on the right bottom, it stayed pretty high. We also sent off an IOA panel, which was negative. There was no causative variance. And, despite doing everything, his labs are not improving. And we decided to send him over to the GN clinic at Montlake for further evaluation as well. And there was thought about maybe trying daratumumab and to try to deplete the B cells to see if it would improve his symptoms. And so I reached out to HEMONC, and they wanted a third biopsy before we considered any further treatment, which is now, I think, it was in May or June of last year.
And the biopsy was sent to us. So this is the third biopsy from this patient. As you see, we have a portion of cortex, 16 to 19 glomeruli. So it was a good sample. This here, 2 to 4 global sclerosis. So in terms of global glomerulosclerosis, there wasn't significant change. And as you can see, still there is some chronic injury. It looks kind of lesser compared to the first biopsy and more comparable to the second biopsy of this patient. Whether, again, it's variation in sampling, there's remodeling, there's reduced inflammation, any of those can be the case. But when we look at the glomeruli, pretty much similar findings. So still we have nodular glomerulosclerosis, as you can see. We have mesangial hypercellularity, as you can see, and maybe actually inflammation and hypercellularity. When I compare this biopsy to the second one that Kelly looked at, I think that this maybe it's even more prominent. Still, we have mesangiolisis, as you can see, and there is fraying of the mesangial areas. We don't have the mesangial condensed black mesangium on Jones state here, and the capillary hypercellularity. So one can say that we have membranoproliferative glomerulonephritis is still there, right? Okay. And some of the glomeruli showed also evidence of scarring. And we have wedge-shaped glomerular scarring here in this glomerulus. And it would be nice if you mark areas with wedge-shaped scarring. And then I can tell you the importance of the wedge-shaped scar. Okay, so the glomerulus on the top right corner is the globally sclerosed glomerulus, right? That's a globally sclerosed glomerulus. But this glomerulus, which is more patent, this is the one that shows wedge-shaped scarring. So let's look at the wedges. These are the two wedges, right? So two wedges. And wedge-shaped scarring, this is the significance of that. So often, typically, the presence of wedge-shaped scarring is indicative or suggestive of scarring from a previously active lesion. So we see this kind of scarring like in post-immune complex glomerulonephritis, in lupus nephritis, those kind of things. But like in the primary FSGS, segmental sclerosis does not look like this. It's obliterated. We see obliteration of capillary. We see hyaline deposition. Those kind of things. There is some hyaline deposition or maybe immune complex. But when we see the wedge shape, we think that, oh, okay, so we had active lesions. Not that we were surprised. And in this case, obviously, we had active lesions. And the capillary hypercellularity and so on and so forth. So we did regular immunofluorescence. I don't have any images, but believe me, it was negative, as it was negative in the past biopsies as well. So again, we went and did pronase digestion immunofluorescence. And here we go. We have a very similar picture to the first biopsy. So again, we have IgG, kappa, and lambda, and we see beautifully IgG and lambda positivity, again, more in the periphery of the nodules, but kappa was completely negative. So electron microscopy was kind of interesting. Maybe there is some variation, but I want to say that the electron microscopy should look a little bit better than I expected. Although, I mean, by light microscopy really wasn't like that. As you saw, the glomeruli was not looking as nice as this electron microscopy looks like. But still, we have some of those inflammatory cells. Also, some of the endothelial cells contained prominent lysosome with those dark material. Still, we had some deposits, electron-dense deposits. And some of the podocytes also showed food process effacement and microvillus transformation. Again, another view, and you see those macrophages containing the dark granules. And our final diagnosis was PGNMID. And basically, we raised the concern that, okay, I mean, the prior one, the prior biopsy that was negative really could be due to variability in sampling, could be due to also some insensitivity of the pronase digestion if the test is not done completely correctly. Or as you heard, I mean, the treatment was stopped at that time the patient was on treatment and then it was stopped. So also maybe at that time we had really less deposits, although by electron microscopy, it looked to me that there were deposits at that time. So maybe more kind of like variation in sampling. Now that you're expert in PGNMID, I have two glomeruli here, and one of them is from a patient with DKD, and another one is from this patient. So could you mark the glom, which is from the DKD patient? Not easy, right? And the truth is that is not that easy always. So sometimes the inflammation in the PGNMID is very prominent, and it's easy to pick that up. And sometimes like this is a ischemic glomerulus, actually, I mean, kind of, or a tubular glomerulus from this patient. And as you can see, the nodular glomerulus is very prominent, but the inflammation is not prominent. I don't have an arterial here to show, but another thing that may help you, not 100%, but in diabetic nephropathy, you want to see arterial hyalinosis, and typically the afferent arterial. But if you don't see, you see prominent nodular glomerular sclerosis, but not arterial hyalinosis. You want to think that maybe it's not diabetic nephropathy. Okay, all right. Now post biopsy follow.
So after his third biopsy, I talked with Hem/Onc, and they did agree to starting daratumumab, and he's been on since October of last year. And as you can see, his proteinuria is finally coming down. Creatinine's stable. It's in the high 1 to low 2 range. But I am seeing him in clinic next week.
Okay, yeah. So I don't know. Do you have any other comment or something, or I can continue?
No, I think he's still on maximal proteinuric therapy, so it's otherwise largely unchanged.
Well, thank you. Now we're at 9:30, so very quickly I would just say that yes, I mean the PGNMID that has been around now for a diagnosis that has been around for quite a few years, and after basically the lesions were described, and we had this classification, multiple studies were out, published about those publications, and also many of them were indicative that, okay, I mean, in PGNMID that the finding of MGERS or monoclonal evidence for monoclonal gammopathy or lymphoproliferative disorders is much less compared to other type of MGERS. You would classify that all of those as MGERS. I mean, about a third, or maybe a little bit less, depending on different studies. And we suggested that, okay, I mean, those cases where we have we can identify a clone if the treatment is basically targeting the clone. That can result to some improvement of the outcome, and in the rest of the patients, maybe if the patients are on empirical therapy or maintenance therapy, that can also lead to improved outcome as well. But I want to actually show you this paper and encourage you to read it if you have not. Probably you have. That is just recently out about PGNMID. In the meantime, we had multiple papers coming from here and there describing like PGNMID cases that they were looked like they were associated with infections, even with vaccination, those kind of things. So it was a question that is it correct to put all PGNMIDs as in the category of MGERS? And in this paper from Mayo, I would say that's very nice in that term that they looked deep into confirming that, okay, there is a clone and the immunoglobulins that are deposited are really monoclonal. And for that, they did two different studies in parallel. One that they used highly sensitive high throughput immunoglobulin referred to our sequencing assay or RaceRep-seq, as well as they did immunofluorescent assay for the variable region subgroups of the light chain. So in this case, they were focusing on the cases with IgG kappa, and therefore for subtypes kappa 1 to 4. So they did those two studies on 56 patients with PG and MID. And what they found was that, I mean, similar to the prior cases, kind of. So the IgG3 was the most common, about 73%. Also, when they did race-rep-seq, they detected a bone marrow clone corresponding to the deposit of hemoglobin in only about 23%, which I should say that it's kind of close to that 30% of finding evidence for monoclonal gammopathy that had been reported by just doing the more routine test. The most common was IgG3 kappa, again, similar to the prior cases. And the low prevalence of clonal disorders was driven by IgG3 cases, so only about 10% of cases with IgG3, they found that by race-rep-seq that they were able to identify a clone. In all 7 clone-negative KGNMID IgG3 kappa cases that were studied by immunofluorescence with anti-light chain variable domain antibodies, basically they showed that the staining for the kappa light chain variants were confirming that there is polyclonality. So basically that ruled out the monoclonality. It was like maybe better saying monotypic for kappa versus lambda, but it was not monoclonal. And also there was a correlation kind of between the race-rep-seq as well as doing the subtyping for the variable region of kappa. Those cases that were IgG1 positive, also in those cases that were polytypic or polyclonal, better saying, there was a suggestion, it's saying, for an infection trigger in those cases. So basically, this paper is suggesting that PGNMID is a heterogeneous condition, as prior reports, some of those were also suggestive, and the predominant subtype most often involves oligoclonal or polyclonal production of nephrotoxic IgG3 and may not derive from a clonal B-cell disorder. And therefore, not all of them should be classified as MGUR. So that's something to consider. And they suggested that maybe we should call PGNMID proliferative glomerulonephritis with monotypic immunoglobulin deposition. These are some examples of how basically race-rep-seq showing the clonality or not showing the clonality were correlating with the isotype staining for the variable lesion of kappa light chain. So when there was a clone detected, also the staining for the kappa subtypes confirmed the monotypic staining for that subtype. And when there was no clone detected, also you see that it is confirmed as well by the subtype staining. So that's an important consideration. In our case, I would say that we have some evidence, at least, for the IgG lambda that correlates with the findings. So probably there's a clone, but I think that this would be interesting. It would be interesting to think about cases that are not typical. If Mayo is putting this test online, we can consider sending those cases to Mayo or start validating it here, which probably, given the frequency of PGNMID, which is not a lot, may not be the best way to do it. Okay. Thank you. If there are any questions, clinical or pathology.
Mhm. Any lasting questions, anyone?
Don't see anything in the comments.
Nothing in the chat either. Well, with that, I want to thank all of our speakers today, including our wonderful presentations from our pathology group.